Okay, well, I just wanted to welcome everybody right now. And I want to say that my name is Kara Jacobson. I'm the manager of Center for Excellence. And thank you all for joining us today. We're going to be starting in a few minutes. And I just want to let everybody settle in. We're going to have a few more people arrive. And for those of you that need CEUs or a certificate of attendance, I'll be putting a survey in the chat box so that you can confirm your participation. If you can't connect to that survey, just type your name and your email in the chat, and we'll be getting you that information shortly after the presentation. If you have any questions for the speakers for our Q&A later, put that in that Q&A section at the bottom of your screen versus the chat section. And later on in the event, we'll have Bob and our panelists answer some of those questions. Thank you again for your patience, and we really look forward to today.
My name is Gary Morse, and as the director for the St. Louis Regional Center of Excellence in Behavioral Health, I'd like to welcome you to this webinar on recovery-oriented evidence-based mental health systems. Just as we start, I'd like to take a brief minute to give a bit of background about the Center of Excellence. Its mission is to promote high-quality behavioral health systems that increase the use of recovery-oriented evidence-based services and improve access, service outcomes, and client and employee well-being. The center pursues this mission through a number of strategic activities, especially in 5 ways: through training, such as today, intensive mentoring and coaching to build provider skills, community education, consultations with agencies, and system-level advocacy. The center is excited to host this webinar, which with our very distinguished keynote speaker and panel really zeroes in on the possibilities of a recovery-oriented evidence-based mental health system. We had, of course, originally envisioned today's program to be an in-person event, but have moved to this virtual environment, which makes everything a little bit more challenging for all of us, but we're glad to have this opportunity to bring people together on such an important topic, as we all do our own little part to be able to help promote everyone's health and safety. And I'd like to just turn it back for a moment to Kara Jacobson, who you may have met at the beginning of this webinar, who's the Center of Excellence Manager. So we're going to provide just a bit more information about CEUs and some other housekeeping issues before we proceed. Kara?
Yeah, thank you so much, Gary. As Gary was saying, and I was sharing earlier, we do have CEU opportunities, and I put that in the chat box earlier. I will put that in there again now. We have a link. Here we go. I'm going to share that right now. So anybody who's looking for CEUs or a certificate attendance, please click that link that I just put. Oh, no, I had to share that to everybody. Let me share that now. Please click that link that's in the chat box and fill all that information out. Or if you want to put your name and email in the chat box, if you can't access that link, we will get your certificate to you. Also, later on, we will have a Q&A. So please chat any of your questions into the Q&A box at the bottom. We also will have a survey at the end of the presentation, so it should pop up when you close out. So if you could fill that out, that would be great too. We look forward to your feedback and for today. So thank you so much.
Thank you, Kara. And appreciate you navigating the Zoom. Who knows, when we went to graduate school that they forgot this essential skill for all of us, like how to be able to navigate technology in Zoom. The St. Louis Regional Center of Excellence in Behavioral Health is hosted by Places for People in collaboration with a range of community stakeholders. We're thankful for the cooperation of all our community partners, and we'd like to specifically thank the Missouri Foundation for Health, which is a significant funder of the Center of Excellence. And we're fortunate to have with us today Dr. Bob Hughes, the CEO of Missouri Foundation for Health. And I'd like to turn now to Bob for his opening remarks.
Well, good morning. Thank you, Gary. It's my pleasure to make a few opening remarks at this kickoff training event at the Center of Excellence in Behavioral Health. Let me start, for those of you that aren't familiar, just with a little bit about Missouri Foundation for Health. At the foundation, a primary focus of our work is strengthening behavioral health systems. In the past, we've supported developmental work for the establishment of the Certified Community Behavioral Health Centers in Missouri and a child psychiatry access pilot project that's now garnered some federal funding to go statewide. Currently, we're supporting the Addiction Medicine Fellowship at St. Louis University and 7 local behavioral health system change projects across the state. And we've just launched a firearm suicide prevention initiative to complement the plan of the Missouri Suicide Prevention Network. So we were excited to have the opportunity to help Places for People establish the Center of Excellence. What a great addition to the behavioral health infrastructure in the St. Louis region. It's the kind of long-term system strengthening undertaking that will benefit the region for years to come. With its orientation on recovery and a focus on evidence-based practices, it will be a valuable resource for people with serious behavioral health disorders, as well as for the behavioral health workforce. The center will also be a resource for interested policymakers and practitioners and researchers who want to continue to learn based on thoughtful evaluation and applied research. And frankly, it couldn't be kicking off at a better time. I think we all recognize the pandemic has resulted in widespread behavioral health problems that are only likely to grow over the next 6 to 12 months. There's a lot of important work ahead, and that work will only be improved by the center's efforts to establish a learning environment for the field. And with that, I look forward to the presentation by Dr. Drake and the panel discussion from regional experts. And thanks again for the chance to be here.
Thank you, Bob, for your remarks and also for all the support that you and the foundation provide for community efforts to build a stronger and more effective mental health systems. The center is also grateful for the support from the SAMHSA for evidence-based practices and for Center of Excellence activities. Kimberly Nelson from SAMHSA is here today with us. Kimberly is the Region 7 Administrator for SAMHSA, an area which covers Missouri and 6 other Midwest states. Kim, if you'd like to make an opening remark as well. Thank you.
Absolutely. So you can hear me probably, but not see me yet. Is that right?
Yeah.
Okay, I'm going to, there we go. There's the camera. Oh, here I am. All right, start my video. Okay, now you can hear me and see me, yes?
Yes.
All right, great. Thank you. All right, I just want to reduce my view here. Oops, no, that didn't work. Let's see. All right, exit full screen. All right, so thank you for having me, inviting me. I am so excited about what's happening here. So I am Kim Nelson, and I think hopefully most of you know SAMHSA is the Substance Abuse and Mental Health Services Administration. We are part of the U.S. Department of Health and Human Services, like other agencies such as the CDC, CMS, folks that you hear a lot from these days. We at SAMHSA are the only agency in federal government that's dedicated solely to mental and substance use disorders. And I'm your regional administrator. I'm your regional representative. Hopefully some of you know me. I live in Lawrence, Kansas, and I serve the states of Kansas, Iowa, Nebraska, and Missouri. So when we are able to, I do spend a lot of time in St. Louis, and have been to places for people and know Joe Yancey and probably several others of you well. So just a few things to think about here. Our most recent data from the National Survey on Drug Use and Health, 2019, so pre-pandemic, have to kind of qualify that these days. 61.2 million Americans had a mental illness or substance use disorder. That data for this last year was an increase of almost 6% over the 2018 data. And that increase was composed entirely of increases in mental illness. Again, that's pre-pandemic. SAMHSA believes in the use of evidence-based practices. If you haven't been out to our website and seen our relatively new evidence-based practice resource center, I would encourage you to do that. It's easy to find. So SAMHSA's website is SAMHSA, SAMHSA.gov. And then once you're there, you can type in EBP or evidence-based practice resource center, and then that'll take you to that part of our website. And this center really aims to provide communities, clinicians, policymakers, just the field in general of behavioral health, which for when we say that, it really means mental health and substance use disorders combined, aims to provide you information and tools that you need in order to incorporate evidence-based practices into whatever setting you are in. This resource center is really easy to search. It's a huge improvement over what we've had in the past. Again, so if you haven't been out there, I would encourage you to. It's dynamic. It's able to be more responsive to emerging issues. Really allows SAMHSA to more quickly develop and disseminate expert consensus information. The way that we do a lot of that is in what's called these guidebooks. And so you can find guidebooks that, you'll see the table of contents, very easy to navigate. They kind of give an overview of the issue, what the current research tells us, some examples of effective strategies, guidance on how to implement those evidence-based practices in your setting, and then resources. This approach, coupled with, again, over the last several years, what we have kind of moved our technical assistance away from a national model into a regionally based, locally based model of technical assistance, which is available for everyone. All right, so, and then, SAMHSA, of course, supports a recovery-oriented, I know we're going to talk today about the recovery-oriented system. We're calling that recovery-oriented system of care kind of ecosystem these days. SAMHSA obviously supports recovery. We kind of, developed, with many stakeholders, I'm sure this definition of recovery, working definition, a process of change through which people improve their health, their wellness, live a self-directed life, strive to reach their full potential. We support that through a variety of funding resources. Starting in 2004, actually, Missourians know this because of your incredible investment in what was then called the Access to Recovery, or ATR funding. Missouri had 15 years, just solid funding of that resource, which has led to a very active recovery supports, coalitions, and community in Missouri. So this ecosystem, of course, consists of, a person's place and life in the community, which might or might not include treatment, rehabilitation, might include support services, peer support, but definitely includes housing, social support, belonging, all of the things that everyone needs. So SAMHSA supports, that framework. Lastly, I'll just say, we can't talk about behavioral health in St. Louis without acknowledging the huge disparities that continue to persist, especially in the African-American community as it relates to opioid overdose deaths. St. Louis is working to address this issue, I know, and I know that you all will be part of that. Just, SAMHSA has what's called an Office of Behavioral Health Equity. Recently, that office produced a publication called The Opioids Crisis and Black African American Population, an Urgent Issue. St. Louis is featured in that publication under community strategies to address this, specifically focusing on engaging the faith community, just one example. I am thrilled to be here and to hear that St. Louis is starting this Center of Excellence, and I just stand ready to help you in any way that I can. Hope you have a great day. Thank you.
Thank you, Kim. We appreciate your being here with us today and all the work that you and SAMHSA are doing for the community and for everyone with behavioral health issues across the United States. This time I'd like to introduce our keynote speaker, Dr. Robert Drake. Bob has held a number of leadership positions in his 40-year career, and is currently the professor of health policy and clinical practice at the School of Medicine at Dartmouth. And he's also the vice president for social policy and economics research at the Westat Corporation. Over the past 4 decades, Bob has been one of the most influential leaders nationally and also internationally in public services for people with severe mental illness. After earning his PhD and MD degrees from Duke University, he has served as the principal investigator or co-principal investigator on over 80 federal or foundation grants, and he's published over 650 articles and books. These endeavors have positively shaped the mental health knowledge, practice, and policy. His own past research includes groundbreaking research and development on the evidence-based practices of assertive community treatment, integrated dual disorder treatment, and especially the individual placement and support IPS, an effective model of supported employment that he co-developed along with Deborah Becker. Bob has also been the leading figure in ushering evidence-based practices into mental health. And this includes his work as a PI on grants from the Robert Wood Johnson and also from SAMHSA, which helped implement evidence-based practices in routine mental health settings, and in developing the federal evidence-based toolkits that have been widely disseminated not only through the United States, but internationally. Bob's work goes well beyond research, however. He's also a passionate spokesperson in collaboration with persons with lived experience in person-centered values and the recovery movement as a cornerstone of mental health policy. I've had the privilege of knowing Bob for about 30 years as a professional and as a friend. And perhaps most striking to me, in addition to his extensive contributions to the field, is the manner in which he goes about his work. A style that is characterized not only by thoughtfulness, intelligence, and dedication, but also by humanistic values, good-naturedness, humor, humility, and most of all, a steadfast caring for the rights and well-being of people with mental health disorder. I think it's no accident that as busy as Bob is, he still finds time to volunteer at a shelter in Vermont. So without further ado, it is my great privilege to introduce my colleague and friend, Dr. Bob Drake. Bob, we're so glad you're here with us today.
Oh, thank you. Thanks very much. So I'll see if I can, this is about the peak of my IT expertise to be able to share my screen, which Kara just taught me before this. I'm really pleased to be here with you folks today, and I'm delighted to hear about the evidence-based practice center that you're building. Gary's over-the-top introduction should be tempered. The truth is, I come from a family with lots of mental illness, and I consider myself a person in recovery. And so for 70 years, I've been trying to figure out how to improve care with only very limited success, but I'm still working at it. And today, what I'd like to do is to talk a little bit about recovery and then talk a little bit about evidence-based medicine and what that means and how these two fields can come together to help us develop a system of care that uses both to the best extent we can. Now, let's see if I can advance this. How do I advance the slides?
So push from the beginning.
From the beginning. Okay, there we go. Okay, so maybe this is going to work.
Oh, push
So,
push it in, up in that your top left corner.
yeah,
Yeah,
I
push
thought I
it.
did push that. Oh, okay,
There you go.
great. Okay,
Got it.
so let's see. So Gary Morse is one of my favorite people in the field, but another is Pat Deegan, whom I think you must all know because of her great work in mental health advocacy over many, many decades. And Pat is great about telling her story, and it really says a lot about the things that we want to talk about today. You know, as an adolescent, Pat was hospitalized with psychotic illness that was labeled schizophrenia. And she struggled for a couple of years in and out of the hospital. And then she says she reached a point where she didn't go to the hospital anymore. But what she was doing was sitting in her rocking chair at home, smoking cigarettes and watching TV all day. And her psychiatrist said, well, you're a real success now because you're not going to the hospital. But Pat's view was that she wanted a lot more in her life than rocking and smoking, and she didn't consider this a success at all. And so she proceeded to do a number of things. She cut down her medicines drastically. She went back to school, ended up getting a college degree and getting a PhD in psychology. She developed a number of programs for wellness. Many of you probably know her Hearing Voices program, her personal medicine program, her Common Ground program, her Recovery Library program, all of which I consider brilliant advances in thinking about treatment and recovery. And in addition to doing all of that work, she got married. She and her spouse adopted a child, and she's just a wonderful wife and mother, as well as a great success in her business. And Pat's really responsible for a lot of what we know about recovery and for a lot of the interventions that have been developed that I'm going to try to talk about. So I'll say a few words about the community mental health movement, but then I really want to talk about recovery-oriented practices, evidence-based practices, and system change that might move us towards adopting those practices more completely. All right, so briefly, you folks know that the community mental health movement really started in conjunction with deinstitutionalization and the Community Mental Health Act in the early 1960s. And one of the problems from the beginning, which we're still struggling to overcome, is that there's been little attention throughout this history to clients' personal preferences about what kinds of services they want and what kinds of outcomes they want. Instead, our system has been driven and developed by professionals, by industry, especially the pharmaceutical industry, by top-down government decisions, and by a variety of vested interests, like hospital associations, and American Psychiatric Association, and so on. And many of the interventions that have been developed and disseminated around the country as a result of this history have been, ineffective and even harmful. I'm going to return several times to this theme in my talk, but let me just tell you my personal history is that, I was trained at Cambridge Hospital in Boston, and it was a very exciting time in deinstitutionalization, and I was involved in starting the first ACT programs in Boston, which was very exciting. But most of what I learned in training, was based on the expertise or the expert interests of the faculty at that time. And, it turns out most of these interventions, and I'm thinking about rapid neuroleptization and Tavistock groups and paradoxical interventions with families and psychoanalysis and on and on and on. Most of these interventions were considered outdated within 10 years. And about 20 years after my training, most of them were considered malpractice, and you could be sued for doing these things. So I tell all the residents and other trainees here that what they really need to learn during training, and I believe this strongly, is how to keep up with things, how to acquire information, and how to change. Mental health is a very primitive field. A lot of what we believe is true turns out to be not correct, and our knowledge base is just expanding rapidly. Okay, so all of this has been helped by the consumer movement, the recovery movement, the evidence-based medicine movement, shared decision-making movement, and the movement towards preferences. And I'll say something about each of these, but let me start with recovery. I've done several reviews of the recovery literature over the years, and it's interesting to me how it gets defined by different groups. People who have actually been involved in their own recoveries talk about this, and this comes from a synthesis by Rob Whitley at McGill. People talk about it as a journey of small steps with a growing sense of really being in charge of their own recovery. They talk about it as a personal and subjective experience. They talk about it in terms of developing relationships, developing a sense of meaning, developing participation in their community. And they talk about the role of the mental health system as being humane, needing to be humane and empowering, but that's not typically what they've experienced. And from the early stages of the recovery movement, I would say in the early 90s, it's to a large extent been co-opted by professionals. People who wrote about recovery in terms of Rogerian psychology and therapy, in terms of social skills training, in terms of skills training in day treatment, in terms of sheltered stepwise jobs, and on and on. And I consider motivational interviewing in this category because motivational interviewing is really based on a process that assumes that the interviewer knows best what you should be doing. And all of these attempts to co-opt recovery are really paternalism, reinvented in one way or another. Our system of mental health continues to be extremely paternalistic. And I could give you many, 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 many examples of this if you're not convinced. And then there's industry's attempt to take over the recovery movement. You know, in the last 30 or 40 years, industry has come up with one, you know, breakthrough, so-called after another. And, you know, we've been through the new medication movement. We've been through the decade of the brain. We've been through the decade of the genome, and so on and so on. All of these, I believe, are based on the false paradigm that there are some specific brain impairments that define specific illnesses that we can diagnose, which lead to specific medications that treat these specific brain impairments and diagnoses. And, you know, there's really no evidence for this. Again and again, we discover that, you know, the brain is much more complicated than we are so far able to figure out. You know, there are hundreds and hundreds of genes and experiences during pregnancy and experiences in early life and assaults in development and adult life that lead to the kinds of syndromes that we tend to call diagnoses. And there's just no evidence that there are specific treatments for any of these either. You know, as a psychiatrist, I have been impressed that we are now still where we were back in the 70s when I was first studying this, and that is kind of empirical trials. You know, let's give somebody a trial of this, and then if it doesn't work, we'll try a different class of medication. It really hasn't advanced very much. And if you are not a believer in what I'm saying, you might read the lovely book by Anne Harrington, history of science professor at Harvard, called The Mind Fixers, where she describes in detail these cycles of failure of the biological psychiatry movement. And then researchers, you know, have also tried to look at recovery. And of course, as researchers, I put myself in this category, we always want to be able to measure something. You know, talking about ethereal concepts that can't be measured is really not something that research can help with. And so we want to measure things. And in general, the recovery, as much as we have lots and lots of measures now and thousands of studies trying to quantify recovery, statistically, it breaks down into these three categories. There's clinical recovery, where we talk about people's symptoms and ability to manage their illnesses. There's social recovery, where we talk about people's functioning in the community. Are people able to have friends, participate in education and employment, participate as citizens in the community, and so on. And then there's personal recovery, which has to do with the psychology of people in recovery. That is, defining their sense of self, improving their self-esteem, improving their sense of agency in dealing with the world, in dealing with the healthcare system. Okay. Lots of people write about recovery processes, and they tend to focus on the same things I just mentioned, relationships, including relationships with treatment providers, as well as family and friends and people in the community. This sense of meaning and participating in normalized or regular roles in the community. Okay. There's a fellow named Mike Slade in England who spent years trying to define recovery and recovery interventions and so on. And Mike lists 10 interventions that he believes are recovery oriented and strongly supported by research evidence. You know, there is the movement to hire peer support workers, you know, within or next to the treatment system. There's the development of advanced directives that allows people to specify ahead of time what they would like to have happen if they experience another episode of psychosis or severe depression. And has definitely I would say that, first of all, the peer support movement has been extremely helpful in the settings where I've worked, because it changes the milieu and level of conversation and respect and dignity. The advanced directives seem to be helpful because they decrease the need for compulsory or the use of compulsory treatments. There's the next intervention is wellness recovery action planning, which is helping people to you know, define their own plan for recovery. And it's really a lot like Pat Deegan's personal medicine plan. There's the illness management and recovery movement that you know, my colleague Kim Musser has advanced over the last decades. It really combines 5 evidence-based practices, you know, including cognitive behavioral treatment, relapse prevention interventions, psychoeducation, and so on. And then there's an intervention called Refocus, which I think is more common in Europe than in America, but it's a manualized intervention for treatment teams in which they spend time talking with each other about how to develop person-centered planning, how to use clients' preferences, and how to promote active goal striving. I've not worked in that model, but it sounds interesting. And then there's the strengths model that, you know, many of us have tried to incorporate in assertive community treatment and other interventions. That was strongly promoted for years by Charlie Rapp and his colleagues in Kansas, and so you're probably extremely familiar with that in St. Louis. And then the final interventions that Mike Slade identifies are recovery colleges, which I think are relatively new in the US, but are used more in Canada. And I like this idea because I've always thought that the education about mental illness and about coping with mental illness ought to be in colleges, community colleges, and so on, rather than in the mental health center. And people ought to get credits for taking these courses and learning this information. And then there's the supported employment movement and IPS that I've worked on for a few years. There's the supported housing movement, you know, which tries to give people choices and control and safe housing, and it's been a great advance. Another one that works extremely well, like supported employment, except that we just don't provide much of it in the US. And then finally, there's another European movement called the Mental Health Trialogue, which is an attempt to establish forums for discussion with the public and to tackle stigma busting head on. And I think we don't do much of this in the US, but we probably should. Okay, now let me switch over and talk for a few minutes about the evidence-based practices. movement or evidence-based medicine. This evolved in Canada and the UK decades ago. And it's really based on trying to bring evidence into decision-making in medical care. It assumes that there are these three pillars or legs of the stool, good science, attention to clients' values and preferences, and clinical experience of the provider. And most important, it's to find a hierarchy of evidence so that, we really, and in this hierarchy, which is often presented as a pyramid, expert opinion is right at the bottom. And that's because it's unreliable and it's often wrong over time. But we continue to rely on it way, 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 way too much, I think, in our policy making and in our decision making. And then on top of expert opinion, things get more and more reliable and evidence-based, as you go to observational studies and randomized controlled trials and systematic reviews and meta-analyses and so on. And, the Cochrane Collaborative in the UK has really been the leading organization in trying to provide these kinds of evidence-based reviews of all medical care, including mental health care. It's great that evidence-based medicine really specifies that clients are the experts about their own experience. We know from lots and lots of studies, for example, that the medications we're always pushing, the antipsychotics and the antidepressants, for example, are only effective for about 60% of people. Well, clients know that also, and they don't want to take the medicines when they're not helping them. We continue to think that medication compliance is next to godliness in this country, but it's just not true. And we need to rely on clients to, be the arbiters of what's effective and what is causing more side effects and so on. Clinical experience is also important. And I think as we present shared decision-making tools to people, which we should all be doing, and the preference laboratory at Dartmouth has developed hundreds of these tools. And what they do is to lay out in very simple terms, what are the alternative interventions for a specific condition, and what do we know about the advantages and the disadvantages or harms of these different tools. And the idea is that the clinician and client look at this as as sort of a map of what the possibilities are, and the client knows about his or her experience with these interventions, and the clinician knows something about his or her experiences with the interventions. And together they make a shared decision making. And I really want to emphasize here that shared decision making is different from motivational interviewing. In motivational interviewing, we're assuming that the clinician knows what's best for the client, and the intervention is based on manipulating the client's ambivalence about an intervention or about an outcome. Shared decision-making doesn't make that paternalistic assumption. It instead says, let's lay out the evidence as much as we can and think about it together and try to come to a shared decision. Okay. There are lots of evidence-based mental health practices as well as medical practices. These are standardized interventions that are defined by manuals and measured by fidelity scales. They're based on controlled research or randomized controlled trials. We insist on more than one research group, being involved in these randomized controlled trials because people are biased about the interventions that they like or they've developed. they're based on objective outcome measures so that they can be repeated across studies, and they aim at meaningful outcomes. And this is really important because, you know, for many years in medicine, we have developed interventions and aimed at things that are really correlates of meaningful interventions. You know, there are second order or even third order correlates. For example, medication compliance. You know, medication compliance is not a meaningful outcome. Actually, feeling better is a meaningful outcome, and medication compliance is only partially related to that. And as I said before, for many people, medications don't work, and so medication compliance is actually a harmful intervention. Okay, here are some of the practices that are commonly identified and have very strong evidence: assertive community treatment, supported employment, supported housing, psychoeducation, and you know, and now suddenly America believes it's discovered early psychosis interventions, even though they've been well established in Australia and some European countries for 30 years now. Let me talk for a minute about IPS supported employment. It's the intervention I know best, and I think it's the best exemplar of a recovery and evidence-based intervention. IPS has been developed by Debbie Becker by talking directly with consumers about what they want and what works for them. It's available to anybody who wants to work. It helps people with competitive employment because that's what they want. It offers a rapid job search because most consumers hate all of these lengthy evaluations and practice sessions. The employment specialist helps to develop a job with a targeted job development. You know, if somebody wants to work with animals, well, we need to talk to veterinarians and pet stores and farms. We don't need to be talking to grocery stores to develop a job. Everything's based on client preferences for when to go to work, how much to work, where to work, and so on. Individualized supports are developed by the client in terms of what they think they need. The vocational services are integrated with treatment so that we can be sure the treatment people are on the same page and offering the same advice. You know, I can't tell you how many clients I've heard say, well, you know, I thought I wasn't supposed to go to work, but then when my doctor told me I could go to work, I was ready to get a job right away. Well, it's just a crime that we doctors have been telling people that they couldn't work for so much time. And IPS tries to make sure people get good benefits counseling so that they know what will happen to their benefits when they go to work. Okay. There are 28 randomized controlled trials of IPS. All of them show that it's better than a variety, every comparator that's been examined, you know, so there is not an evidence base like this for most interventions, but there should be if we really had data-based and evidence-based systems. IPS is a recovery intervention, I think, because, you know, it's totally based on clients' choices and clients' goals and helping people to find employment that doesn't just increase their income, not just a job, but a job that fits who they are and provides the structure and self-esteem and community integration that they want in life. And IPS has spread around the country, not because of federal support. You know, the CMS continues to fail to help fund the service. And so for most mental health centers, it's a money loser, but something they provide anyway because it's so important to recovery. And one of the things that's helped the spread and development and research of IPS is the learning community, which I encourage you folks in your evidence-based practices center to use. And we can talk about that more later if you'd like. Now let's switch over. In the last few minutes, I want to talk about developing a recovery system and recovery evidence-based system. But the recovery part of the system, needs to support people's individual ideas about their personal recovery. It needs to provide relationships that are based on, respect and dignity and mutuality and so on, which we haven't done during most of the years I've been in the mental health system. It needs to have a huge organizational commitment. And we're far, far from this in the US now, which I'll explain. And it needs to address the public and needs to address the constant media attention that promotes stigma in our society. And again, I think we're far, far, far from doing this so far. So the American mental health system is amazingly far from this kind of recovery evidence-based system. When those of us who study health services are constantly faced with the paradox about American healthcare. And that is that we spend more on healthcare than any of the other 40 high-income countries in the world. And our outcomes are consistently at the bottom or near the bottom. And so we have to be thinking about constantly, how is it that we spend so much money and we get such lousy outcomes? And the lousy outcomes extend across all of medical care. Virtually everything that's been looked at, we have poor outcomes compared to other high-income countries. And why this happens, some researchers have identified, we put a lot more money into pharmaceuticals, we put a lot more money into high-tech interventions like imaging, we pay a lot more for doctors, we pay a lot more for hospitals, but essentially, all of these things are based on top-down policies that are determined by government, by professional organizations and guilds, by the extremely toxic effects of the pharmaceutical industry, and by all of the vested interests that control our healthcare system. And I'm sorry if that offends a lot of people, but I believe that's the reality in the United States. We continue to finance non-evidence-based practices, redundant medications, and non-recovery oriented services. And we actually pay very little proportionally for the recovery-oriented services that consumers actually want and need. I talked to you a bit about my own training and my recognition early on that clinical wisdom is often just wrong. It's not what we should be developing our system on. And yet I see out around the country, lots of these folks who make a living by providing expert opinion and expert advice to states and to mental health systems. And they are way behind the times typically because the evidence is developing faster and faster, even though there's still long delays in implementing evidence-based practices, we're developing new evidence. If, you know, those of you who followed carefully what we've learned during the COVID pandemic are very aware of this. It's just amazing to me that we learn new things about RNA viruses almost every day scientifically. I think all of this understanding is probably, well, some of it is involved in the incredibly rapid pace of developing vaccines, but after this pandemic is under control, we will know thousands of times more about viral illnesses and RNA illnesses than we did before the COVID pandemic. And we'll need to be thinking about how to incorporate that into the way we care for infectious disease. We are also, by the way, just learning amazing things about the immunologic system and how it works and how it responds to viruses that should affect care dramatically in the near term future. So how would we develop a recovery evidence-based system in mental health? Well, there are a few things that we know we need to do. You know, one is to start with values, that we really want to be helping people achieve the kind of relationships with providers that they want, and we want to be helping people to achieve the kinds of outcomes they want. We can't be, you know, continuing to send the police out for a mental health crisis. We can't be continuing to house people in jails because there are not enough hospital beds available and they didn't get the prevention services that would have prevented the crisis way before it happened. We need to be working towards the kind of humane and empowering mental health system that Rob Whitley has been talking about for decades. And this is going to require widespread systemic changes to fund the kinds of services and the kinds of choice processes and the kinds of goals that people who use the system have. And there needs to be an enormous organizational commitment to this process. I mean, it's a wonderful thing that SAMHSA kind of tries to promote these good values, but SAMHSA doesn't have much money. SAMHSA doesn't control the system the way pharma does, or the way that CMS does, or the way that states do. And we need to get through to the funders in order to institute real and lasting changes. And if we could do this, I believe the focus of consumers, as well as the focus of science, pushes us towards looking more and more at social determinants. You know, we don't get lousy outcomes in the US simply because we misspend money on healthcare. We also get lousy outcomes because we don't pay attention to social determinants, and we don't pay attention to the social services that should be integrated in our health system. You know, people need food and financial security. They need safe housing, meaningful relationships, or meaningful activities and supportive relationships. And if they have those things, they're not going to spend their time having mental health crises and going to emergency rooms and waiting in emergency rooms for days for a hospital bed. And more than developing an entirely new crisis care system, which I know SAMHSA has been sponsoring, we need to go back and focus on these social determinants so that we're preventing crises rather than, you know, it's the American way is to medicalize everything and provide more and more medical care for services and conditions that could be prevented. We need to focus on prevention and on social determinants. And when we get to funding actual services, we need to focus on clients' goals. So a recovery-oriented, evidence-based system would dramatically change funding. The funding for pharmaceuticals in this country, which is already just gigantic compared to any other country, just keeps going up logarithmetrically. It grows and grows at a pace that's totally not justified by the science. And we need to change who's controlling the decisions that are leading to this, misuse of funds. We need to change the options that clients coming into our system actually have. We need to focus on the goals that are important to them. We got involved in studying supported employment because the director of mental health in New Hampshire came to us at Dartmouth and said, look, could you help us with something? Every year we do a survey of clients, and every year they say the number one thing they want from the mental health system is jobs, and we do nothing to provide jobs. We don't know how to help them find jobs. And that's how we got started studying different employment systems. And by the way, the first thing that we found out in doing initial studies was that all the expert opinions that we got from the so-called gurus about psychiatric rehabilitation were just wrong. We're just wrong. It didn't take 9 months of therapy to help somebody figure out what kind of job they wanted. Most people, over 90%, knew what kind of job they wanted immediately. It didn't take 6 months of skills training to help them get ready for a job. It didn't, and on and on. But we still need to change, our attitudes about these things, because, everywhere I go, I still see systems that are based on the idea that we know best what people need, and we don't need to listen to what they think they need. Our systems are still terribly paternalistic. I've gotten hammered by professional organizations and the medical school and so on when I give talks about how medications work, because essentially what these experts say is, well, you don't really want to tell patients and their families the truth about how these drugs work and what we know about them. They might stop taking their medications if they really know the truth. Well, that's a horrible attitude for us to be promoting. We need to work with consumers and family members in order to do what they call co-production of health and recovery, planning these systems together. And I think the best way to do this is by providing or starting learning communities that include all of the stakeholders in figuring out, what do we need to do next? What do people want? What's the problem in the system? I've been so impressed watching the IPS learning community from the outside. They will, the people who are involved on the ground know what's really going on. They came to us and said, look, we have this big problem now that so many people in the mental health system have a criminal justice history, and they're being screened out of jobs. How can we work around that? And so it only took a few studies to figure out how to work around that now. And it's part of the basic training for IPS employment specialists now. But that didn't come from the experts. It didn't come from government. It didn't come from the pharmaceutical industry. It came from clients and employment specialists on the ground. So I encourage you with your new center to be thinking about taking this approach to learning communities, setting up learning communities among practitioners, and setting up learning systems within your state too. You know, learning systems should be collecting data, looking at doing small experiments all the time so that we know better what we should be doing and what people want and what's effective. It's always amazed me that, you know, and I consult with about 30 states. It's always amazed me that they're trying to run these big systems without good data, but they haven't had good data because they haven't collected good data. You know, when I worked for the state of New Hampshire, it always amazed me how easy it was to do a small survey across the state and how surprised the state mental health authority was to see the data. They had no idea what was really going on in their system. Well, we should be able to change that pretty easily. We should be able to develop, you know, learning communities and learning systems of care. So I'm going to stop at this point, but what I've tried to argue for is that we develop a new paradigm in the mental health system. And this paradigm should value users rather than industries and vested interests. It should include the users in conceptualizing the system, studying the system, designing, redesigning the system, implementing interventions, delivering interventions, monitoring interventions, and constantly revising our policies as the evidence changes rapidly. And in order to do this, to develop this kind of new paradigm, this new system, we're going to have to figure out how to shift funding. We can't continue to you know, send most of the mental health budget to the pharmaceutical industry without insisting on any real return on our investment. And how to do that politically, I don't know, but that's the challenge ahead of us. Okay, so I'm a researcher and I am required to disclose my funding sources. And I've been fortunate over the years to be funded by a lot of great institutions and a lot of great foundations, which are mostly family driven foundations. So here's the list. I appreciate what these folks have helped us to do. The kinds of things I've talked about, I hope are all based on good evidence. If you would like research articles, please call or write to Susan Morris, our wonderful, wonderful administrative assistant here, and she will send you what we think is the best evidence for any of the things that I've argued for. So thank you very much again for inviting me. I hope I haven't offended everyone with my iconoclasm. I know that I do that sometimes, but I believe strongly that if we can you know, really keep our eyes on recovery and on the evidence base, we can create a much, much, much better, healthier, more functional mental health system. I'll stop here.
Well, Bob, thank you so much for sharing your years of experience in terms of recovery. And I'll just personally say that I was not offended at all. And I really like much of what you said. It gives us much to pause and think about. I would also like to ask all of our participants at this point to give Dr. Drake a warm Missouri thank you virtually for him taking the time with us this morning.
Well, it's my pleasure.
All right. At this time, we're going to pivot to our panel. And I would, there's so much I can say about the 5 behavioral health leaders from state, region, and local that are joining us this morning. But in the interest of time, I'm going to be fairly quick. We have Laurent Javois, who is the Regional Executive Officer for the Missouri Department of Mental Health. We will also have Suzanne King, CEO of Mental Health America of Eastern Missouri. Wendy Orson, CEO of Behavioral Health Network of Greater St. Louis. Natalie Cook, who is the Eye Health Care Transformation Manager for the Missouri Coalition for Community Behavioral Health Care. And Jama Dodson, who is the Executive Director for the St. Louis Mental Health Board. I am going to, in the interest of time, ask each of our panelists to please limit their comments to 6 minutes. And I would ask them to respond to the following 2 questions. Please respond with any general reactions that you have to Dr. Drake's presentation. And 2, what do you see as the assets and challenges in achieving a system of care that is truly recovery focused? All right, well, then we'll get Laurent in a minute here. Let me move then to Sue King, CEO of Mental Health America of Eastern Missouri. Sue?
Awesome. Can you hear me?
We can hear you.
Okay, good. Good morning. I'm so grateful for the opportunity to join Dr. Drake and the other panelists this morning for such an important discussion. Historically, we've focused more on the crisis end of providing services. And while I truly believe that's important, I also believe we must really commit to the front end. So prevention, early identification, and early intervention so that we can have greater impact on people's recovery. If we want to become a system of care that is truly recovery oriented versus reactionary, we need to start addressing the root cause of so many issues: childhood adversity, adverse childhood experiences, adverse community environments, and racial and health inequities. We know that early adversity are traumatic experiences that can have a profound effect on a child's developing brain and body, with lasting impact on a person's emotional and physical health throughout their lifespan. Research has shown that 1 in 3 adult mental health conditions relate to adverse childhood experiences. In the original 1985 Kaiser study, we understood the outcomes that early adversity can have on adult health. We now know the how, and that the biological mechanism is our stress response system and toxic stress. As I'm sure you know, toxic stress is defined as an extreme, frequent, or extended activation of our body's stress response system. Early adversity leads to a disruption in our neural development. It actually changes the shape of our brain. This disruption leads to social, emotional, and cognitive impairments. Impairments in these areas interfere with our ability to have healthy relationships, to maintain employment, to even regulate our emotions. And once that happens, people begin engaging in high-risk behaviors, things like excessive drinking, promiscuity. All of this acts as a domino effect and leads to disease, disability, and social problems. That's when you start to see serious physical health issues like cancer, heart disease, diabetes, as well as mental illness, schizophrenia, bipolar, anxiety, and depression. And ultimately, there's a shortened life expectancy by as much as 20 years. The most fascinating point, as well as what I believe should be a significant area of our focus, is that toxic stress is passed down from one generation to the next. It is transmitted from parent to child more consistently than any other genetic disease. However, not all childhood adversity has a negative impact, and that we have found having one buffering adult in a child's life can profoundly impact them for the better. Toxic stress affects our earning potential, how we learn, our parenting approach, our ability to have healthy relationships, what we create in our communities, as well as the very idea of what we believe we are capable of. This information is fundamental to addressing health inequity and the social determinants of health, Because when you bring everything down to a cellular level, then it's all about all of us, and it's no longer an us versus them conversation. I was so glad to hear Dr. Drake bring up prevention and the social determinants of health, because the second component necessary for a recovery-oriented system of care will require that we understand how social determinants of health impact our health outcomes. If we think about Maslow's hierarchy of needs, we have to remember that people's basic needs are safety, shelter, and food. If the community we live, work, play, or worship in is unable to provide any one of those areas, then that will have a detrimental impact to our mental and physical health. In order to develop a system of care that is recovery-oriented, we must engage in a diverse group of stakeholders in developing policy goals. Policies that will support efforts to address adversity that is embedded in our communities, but have their roots in our systems. Think about what could happen if our system could begin screening for adverse childhood experiences, and we began helping a pregnant woman understand her ACE score and how that would impact her child. And this was all done through a lens of equity versus judgment. The initial investment in that family would be vastly different than if we wait until the child starts to display social or cognitive impairment. Or 10 years later, that same mother has to go to a doctor because now she has diabetes or cancer. Not only could we strengthen the families and communities, we could redistribute money to invest in building equity within our communities throughout the state. All of this simply perpetuates the problem of framing it in terms of us versus them. It's either we get ahead or they do, and fighting for resources that fragments efforts to solve the same problem. The science shows us that it is not us against them. We share a common enemy, and that is childhood adversity. And that should be at the core of building a system of care that is committed to recovery, that starts with the foundation of prevention. Thank you.
Thank you, Sue. I think we have Laurent now. So again, Regional Executive Officer for the Missouri Department of Mental Health, Laurent.
Thank you, Joe, and thank you for the opportunity to participate today. It was really inspiring to hear the remarks of Dr. Drake, and I was particularly intrigued to learn about some of the newer recovery interventions, both in this country and abroad. It gives me a lot of hope. With respect to the question you posed, Joe, I think that there are obviously many benefits to a recovery-oriented system of care. And so I won't spend much time on that. What I'd like to focus on, though, are some of the challenges that I see in building such a system. So I'd like to start out by saying that recovery system development is well underway in the state of Missouri. We have a strong and active recovery network. We have some 879 active certified peer specialists in the state. There are 1,200 accredited recovery housing beds in Missouri. We have some 53 recovery support providers and 4 recovery community centers that offer a great deal of peer support. So we're off to a good start. However, in a state with a population of 6.1 million people and a mental health department that is supporting services for approximately 170,000 individuals annually, there is room, indeed, there is a need for growth. So aside from funding, which we know is probably the biggest challenge, a couple of others come to mind as we strive to grow the system. One is adopting the core values of a well-designed system. Many practitioners find it difficult to partner with people, their families, and advocates to develop, implement, manage, monitor, and evaluate systems. That is simply not the way we've traditionally done this work, and making the shift is difficult for many. Another is embracing cultural diversity. In a city like St. Louis, for example, we have a very diverse population. And so it's very important for providers to ensure that their staff understand the cultural diversity that exists in the community and prepare themselves to be able to work with all people that are likely to show up at their doors. Collaborating across agencies and service systems. We do not do a very good job of that in Missouri. There's some collaboration, but particularly across systems, it's very challenging. We don't share enough information. We don't seek out our partners in other agencies sufficiently and learn from each other and plan together. And something else that I observe frequently is the use of stigmatizing language. We have to get away from that. We have to abandon it. More providers also need to figure out how to address the broader range of support needed for people seeking different pathways to recovery. We can also do a better job of empowering individuals to tell us what will help them get better. We should grow and strengthen the peer workforce, allowing these experts with recovery experience to play a bigger role in the system of care. Another challenge I see is fully embracing some of the key elements of person-centered care. For example, welcoming entry into the system at any time, regardless of prior treatment or that individual's history in treatment. Reliance on global assessment rather than a problem-focused approach as we work with individuals. Greater respect for individual choice. Individuals we serve should have a much greater voice in the services they choose, the way they will receive services, and the way they'll participate in our programming. And finally, we should build on the strengths of the individual, family, and community. These are some of the challenges that I've observed over time. We are getting better, but we have a long way to go. And that's why I'm so excited about having the Center of Excellence here in St. Louis, where all of our providers, as well as consumers and their family members, have the opportunity to access high quality information that will help all of us to do a better job going forward.
Thank you, Laurent. I'd now like to bring on Wendy Orson, CEO of the Behavioral Health Network of Greater St. Louis. Wendy?
Great, good morning and happy Friday, everyone. I am super pleased to be a part of this kickoff with the Center of Excellence. I think this is a huge asset and resource in our community, and I'm just really grateful to have been a part of the dialogue with that, and especially grateful to be here with Dr. Drake today as we talk about recovery-oriented systems of care. A couple of reactions to Dr. Drake's presentation that I'll be candid on. One thing that really struck me, and I absolutely love and agree with some of the chat as far as the candor and the honesty and really stating what he believed, and that was about motivational interviewing. You know, I've been an advocate of motivational interviewing. We train our peers on motivational interviewing, and we check off the box. And we don't intend to check off the box, but we do. But what really struck me was the paternal component of that and the manipulation in motivational interviewing. And that's a point that I hadn't heard being made, that without, you know, there are key components to motivational interviewing that I think are very strong and important, but without having the sentiment that the patient knows best, you're really missing the mark. So I really appreciated that he brought that to light, and it really was a reminder for shared decision making that I thought was really key. One other general reaction that I had too is when was the story about Dr. Pat Deegan. You know, and BHN serves as an incubator for programs, for example, and we look at outcomes a lot and how are we going to do this. And some of our outcomes are we've reduced hospitalizations, we've reduced inpatient, we've seen patient compliance. This is all wonderful. What great success we're having with this project. That's not success. And I absolutely love that he brought that out, that success is personal achievement and professional growth and quality of life and meaningful outcomes. And I think that was a great reminder to leadership that while yes, you know, cost savings are important, and yes, reduction in hospitalizations are important, we have to really look at this from a client first lens and have more meaningful outcomes that we're really hoping to achieve. The others are important too, but they shouldn't be the ones that are out there. So that really struck me, and I just wanted to thank Dr. Drake for that reminder. Some of the challenges that I'll note, they probably mirror some things that Laurent just stated, but I'll just say them anyway because they're differently stated. Dr. Drake really noted organizational commitment. And I think that every provider that I've worked with in this region has a commitment to recovery-oriented systems of care, but system and culture change is hard. It's hard. Offering a recovery-oriented system within our traditional service system doesn't work. We have to change the way we do our traditional systems. That wouldn't be sufficient. So it requires culture change, system change, and breaking down that traditional service system that we've relied upon and doing it differently. And that's hard. So that becomes somewhat of a challenge. There may be a reluctance by internal and external stakeholders to change. For so long, we've known what's best for our patients. We've known in some cases if they're even ready for treatment or not, and we make that decision for them. And that can't happen in a recovery-oriented system of care. So I think that that's something that we have to really look at and address that reluctance to change. Another challenge, and I think Laurent mentioned this, is workforce and training needs. I think that's something across the board that is a challenge for all of us. There needs to be a greater level of capacity building for a workforce that's diverse, that's culturally competent, that's trauma informed. And when we talk about that, we need to be able to reach out to ethnically diverse populations and support recovery settings in places where they're comfortable. So I think that that's really important. And then creating real opportunities for growth, development, inclusion, decision-making, and peer leadership is a challenge and something I think that we really need to do, because we say, oh, we've got 10 peers, but are those 10 peers in leadership positions impacting change within the organization? Are they diverse? Do they reflect our community? All of those questions have to be asked as we look at the challenge of workforce and training needs. The other thing I would say that I've seen, and you know, I've worked on the mental health side in the provider world and substance use, and now I get to kind of do a combination of both. But there's different philosophies and perspectives of recovery. There's different language as to what recovery means and how we define it in mental health and substance use treatment systems. We have to be able to get to common language. I think that's really important to do that. And there's still those judgments or biases of what it means to be in recovery and substance use and what it means to be in recovery and mental health. And each one of those entities or people within those systems may judge a little bit differently based on where they're at. So those are a few challenges. And I had written down and thought about this question in advance, and resources to me, you know, not having sufficient resources to implement large scale change is a challenge. But in hearing Dr. Drake, his perspective was very interesting in that we may have enough financial resources, but we just have to be able to change them and what we use them on and how efficient we are with them. So I thought that was really interesting. And I absolutely 100% agree with Laurent on stigma reduction. I think that's key in everything we do. And lastly, as we talk about assets, strong leadership is a significant asset into establishing this. And this is critical not only in establishing our vision, our mission for what we want to do, but guiding policies and procedures in order to make these changes and practices, and engaging stakeholders in creating culture of change. We do have in this region, I think, decent cross-system collaboration in some areas, but as Laurent mentioned, there's a long way to go. There was a question in the chat that asked about how do hospitals engage in this? And I think that's really key, because recovery-oriented systems of care are not just built in mental health and substance use disorder treatment clinics. they are inclusive of stakeholders like community members, community organizations, people in recovery. They all have to be involved in this change process, which is why a center of excellence, I think, can help bring all of those stakeholders together. So those are a few assets that I think that are critical into achieving a system of care that's truly recovery oriented. And I think I'm at my time, so I'm going to stop there and thank you again for the opportunity to participate on this panel.
Well, thank you, Wendy. Next, Natalie Cook. Natalie is the iHealthcare Transformation Manager for the Missouri Coalition for Community Behavioral Health Care. Natalie.
Thank you. So something that really, I guess, kind of jumped out to me that Dr. Drake had talked about was the payer system. And so, you know, being a statewide coalition, we find it very important to, you know, build relationships and have good partnerships with the payers in the state that that our providers are relying on. So, you know, we build good relationships with the MoHealthNet division, with the Department of Social Services, with the Department of Mental Health. Even, you know, at our level with the state budget office, Brent, our CEO, has, you know, numerous meetings with them to advocate for the behavioral health system in Missouri so that we can do the things that we know we need to do. You know, we strongly advocate for improving service rates. We know that providers can't implement evidence-based practices. They can't implement innovative care to lead to better recovery outcomes if there isn't a payment system that supports that. So those are things that we're really working on improving in the state. You know, with our certified community behavioral health organizations, expanding those so that more areas of the state, the entire state, hopefully will end up with having a CCBHC within their area so that it breaks down those silos. They can walk into that CCBHC and get the service they need, whether it's mental health or substance use treatment or both. So, you know, and then they're also having, even within the CCBHC model, their physical health addressed. So, you know, we're really looking at serving the whole person. And I think Missouri's done a great job of moving in that direction throughout the years. And we're going to continue to improve upon that. We know we need to continue to improve. We did talk about outcomes, and I agree with Wendy that an area where we struggle a lot in this state is outcomes of successful recovery. You know, we can show cost savings in programs, and again, that's important. We have to be able to do that to satisfy our payers, to satisfy state legislators. But you know, how are we improving lives for people?
Did we lose Natalie there?
It looks like we might have lost Natalie.
I think we might have. We'll see if we can get Natalie back to finish her comments. But at this point, I think we'll move on to Jama Dodson.
Oh, Natalie, did we get you back?
Are you back now? Okay, there she is. Go ahead, Natalie. Sorry.
So we want to be able to use data and figure out how to use data in a way that will measure recovery success. We've been working with, you know, academics at the Missouri Institute of Mental Health to help us figure that out. So I think it's a direction we're moving in. We're just not there yet, but we're going to continue to work on it. You know, specific with implementing systems that show recovery. One thing that we're currently working on that I'm very excited about is implementing the ASAM criteria. That's the American Academy of Addiction Science. So we're really wanting to move all of our systems into these, you know, these more gold standard type treatments that have shown positive outcomes. But again, you know, we need to figure out how we can put those positive outcomes into a meaningful way to present them to others. So those are the things that I, was just kind of jumped into my mind as I was listening to Dr. Drake and the other panelists today.
Thank you, Natalie, and thank you for being on the panel this morning. Finally, Jama Dodson. Jama is the Executive Director of the St. Louis Mental Health Board of Trustees. Jama.
Yes, now I'm unmuted. Okay, let me get something off here. Good morning, and it's great to be with everybody here today. I found it very interesting, Dr. Drake's talk, but also the comments made by the other panelists have just been fascinating as well. I am not a social worker or a clinical person at all, so I guess one of the things that I felt like in my general response to Dr. Drake's talk was, I think it would be good and healthy if everyone who works in the mental health system actually kind of took a meditation moment and asked themselves, what are your assumptions about the people you work with? I think assumptions lead to behavior in the way we treat people. I think assumptions are oftentimes unconscious. They aren't intended, and we do all these things to help people, but in the backs of our minds, we may be seeing them as flawed or as unable or whatever we may be doing that knocks that person down in some respect. So that was my reaction, that we need to examine our assumptions. Also, I was thinking in the payer system, maybe the payer needs to examine their assumptions about the providers always trying to skim off as much as possible. Sometimes the little controls that are set in place by the payers are just impediments to being able to do what you really need to do. But I'm not an expert on that, so I won't go into that too much. But some of you who know me know that I spent most of my career in youth services before I became a funder. And I remember, and I'm sure many times have heard the Frederick Douglass quote, "It's easier to build strong children than repair broken men." And it's my belief that when we strengthen resiliency when children are young and as they grow, there'll be less of a need for recovery, or at least recovery will be easier to reach when services or treatments needed. We do know, however, that a lot of behavioral health conditions have their onset in childhood. And I was thinking, as some of the other panelists talk, wouldn't it be great if more of if the mental health and the physical health were more integrated? I know that's been a desire. I know that's been a goal. It's been seemingly very hard to achieve, but go to your pediatrician visit, nobody thinks a thing of it. And at that time, there's a little assessment that could be done to help the parents understand and to know whether things services need to be made available to that child and family. Usually when they're young, it's both. And I think that though early childhood's a critical time of development, there are opportunities at each stage of the child's life, all the way through adolescence and adulthood, when intervention can make a difference. And because I sometimes feel like there's this competition between the early childhood, the school age, and the older adolescence. I think there's opportunities for youth development all along that way where resiliency can be supported and developed. There's been a lot of research in the past 50 years, so we do know a lot about what works. And a few years ago, MHB hosted a symposium about prevention and invited Dr. David Hawkins, who's a social work researcher from the University of Washington, to speak with us at that symposium. And one of the points he made that stuck with me was to prevent a problem before it happens, address its predictors. And, there's so many things that we see, and we've been talking about social determinants. I mean, look at the predictor of that behavior and try, and research is out there that helps us to identify that. Another point he added was untested good ideas can make things worse. And I really also believe that. Dr. Hawkins shared features of the website blueprints.com that allows practitioners to search for an evidence-based program or intervention that addresses the behavior or indicator that they want to work on. And I'm sure there are many other sites. That was just the one that he shared with us, that we would be able to provide, they could search, look into what the situation was that was trying to be addressed. Again, it fits nicely even with, patient-centered or client-centered work, because you can talk to each other about what you're seeing. What sounds better to you? Would you rather do it this way or that way? There's a lot of opportunities if you think about it. The research shows that by building protective factors, problem behaviors will decrease even when risks are present. So we can't give up or feel hopeless about these kids or any of our clients. Just because risks are present, there are things that can be done to strengthen them. So evidence-based interventions that address both risks and protective factors can be really effective, assuming that the practice is delivered appropriately. And that brings me to some of the challenges. And I certainly don't have all the systemic ideas that my colleagues had. I found those fascinating. But some of the things we hear from our providers when we try to work with them to encourage them to use an evidence-based practice or program is that evidence-based programs can be expensive, and they don't have the money to implement it to fidelity. And that I say that there are affordable ones. Choose carefully and build an infrastructure so that you can self-maintain that is one way of getting at that issue. The other challenge is that evidence-based approaches are not always welcomed by staff who may feel that their training and experience is being challenged or undervalued. And finally, evidence-based approaches are not widely understood or embraced by the larger community, and that includes us funders. So there's very little incentive for organizations to use them, or if they do use them, everybody's using a different one. So you never really see any kind of collective community level changes being made. So I don't want to stop on a down note. I do feel like that this is a great topic for us to take on. And I know that the Center for Excellence is going to be a big help in that. I want to thank Joe and the staff, and I really appreciate being here today.
Thank you, Jama. Join me, please, in giving a big thank you to all of our panelists. We appreciate your expertise and we appreciate your view. Thank you very much. At this time, I'm going to turn it over to Julie Blanco. Julie is the Director of Training and Technical Assistance for the Center of Excellence. And Julie's gonna kind of monitor the Q&A. We have a limited amount of time for Q&A, and if there's questions that are out there that we're not able to respond to, we will try to get those answers to you. It will be after the webinar though. Julie?
Thank you, Joe, and thank you to everybody. This was so great, and people are putting in really good questions. So please keep popping those in, and we'll get to as many as we can. One of the thing that came up several times, Bob, was something pretty practical about IPS services. We have people from other states and maybe even other countries on the webinar today. And so people were interested in how do they find out if there are IPS services available in their area? Is there some sort of main database, or what's the best way to search for IPS services in people's local areas?
So the Department of Mental Health in every state, I think, has a vocational leader who could identify exactly where IPS programs are. They're in 20 countries now, and many countries have done a better job than the US because they have a real healthcare system. But in the US, IPS is pretty widely used in over 80% of the states. There are now about 1,000 programs. So if they just call the State Department of Mental Health and ask for the person in charge of vocational services. They should be able to find out.
Okay, thank you. Questions on outcomes came up several times. Kind of what are your thoughts, Bob, and anybody else on the panel, about what are some of the most appropriate and best outcome measures or tools that programs should be using? What sort of rating scales and the best way to work that into into organizations?
Sure, well, I'd be glad to give my opinion, which is that, we should focus on the positive things that most people want. And so, we have a set of outcomes that we use in some of the programs that I work with. And they are like, do people have safe housing that they're satisfied with? Do people have an opportunity for education or employment that they're satisfied with? Do they have friends that they see regularly, who are positive and not drug purveyors? And, are they managing their mental health issues in a way they're confident about and making progress? And are they managing their substance use issues in a way that they're confident about? And we just use 5-point Likert scales to measure those things. They add up to quality of life, and we measure them every quarter so that you can see people's progress over the year and over years. And you can also see areas where they're not making progress, which is what we think ought to be, part of the shared decision-making discussion.
Some other questions came up about in such an important issue around people having meaningful lives and meaningful recovery in their life was involvement of families and significant others and sort of natural supports, and thoughts on what are the best ways to get education out to families and to really get families involved in treatment.
Mm-hmm.
Any thoughts on that?
So again, we started a program for people with co-occurring mental illness and substance abuse 20 years ago that's really thrived, and I still work there as a consultant. And one of the main tenets of the system is that families need to be partners in the process. And we developed a family support and education intervention and manual that's based on a lot of the well-studied family psychoeducation interventions, but is more empowering of families and treating them as partners. And we really insist on the families being involved by telephone every week in the first year of somebody being in treatment.
Yeah, I trained my staff on that module.
Oh,
IPCD.
great.
Yeah. And some questions about, it felt like a lot of this discussion, and rightly so, but is focused on maybe more of like, let me see, now I lost that question. Do you feel like this is focused on a very particular population, for instance, people who are homeless or lower socioeconomic, or do you feel like these concerns would are these things that we've been talking about are appropriate for all populations in mental health services?
Well, the public mental health system in our country, attempts to provide services for people with more severe illnesses and fewer resources. We have, one of the ways we spend so much money in this country is that we have a gigantic private sector that you know, sucks money out of the system. I think that lots of people who are in the private system, though, would actually do better if we provided evidence-based practices. You know, when I first came to Dartmouth, there were a lot of Dartmouth faculty kids getting terrible care, private care over at the medical school. We were able to transfer them to the community mental health center where we got them, help them get better.
Mm-hmm. And I think we have time for one last question. I will put that again to you, Bob, but if any of our other panelists want to jump in on this one, please unmute yourself and jump in. The person asked for you to please speak a little more to what you meant by organizational commitment and what it looks like, particularly given that often the behavioral health system is very fragmented and siloed.
Yeah.
An easy one at the end, right?
Well, you know, we just got a grant from the Department of Labor called Aspire. And the focus of the grant, which Missouri could apply for, is to help all the agencies at the state level collaborate. And that, of course, needs to happen at the federal level too. I've had any number of meetings with, you know, several agencies like HHS and Labor and Social Security. You know, the government has, I don't know, something like 100 different agencies that fund care in one way or another for people with disabilities, and they don't work together at all. And, you know, they all speak up for collaboration. And as soon as you start talking about sharing money, they all jump out the window. So if I were you working at the state level, I would work hard to get these different agencies that are, you know, you're not going to change the feds and those federal agencies are not going to begin to be reasonable until Congress forces them to. But at the state level, you know, you really should have some capacity, and the Aspire grant is aimed at this, to get those agencies together, you know, from the governor's office all the way across healthcare and vocational and disability and entitlement organizations, et cetera, to try to have a consistent vision and a consistent funding mechanism and you know, and I would really be in favor of a system that, you know, funds more local control and decision-making. You know, that if it just amazes me how the learning community on IPS figures out things that are really important to people that, you know, never even occur to anybody at the higher levels of administration, you know. But so we ought to empower these, you know, multi-stakeholder learning communities at a more local level, and let them decide, you know, do you really want to send half of your funding to pharma? Or would you rather figure out how to use it locally for things that clients really want, you know? We don't, it just amazes me that I see clients come into our center on 15 medications now. Well, imagine all the money that's wasted on that. And I've seen a bunch of them that we've slowly gotten them off, all 15, and that we can't find anything wrong with them at that point.
Yeah. All right. Thank you so much, Bob, and thanks to all our panelists. I think we're going to squeeze it in just in time. I want to make a quick announcement. We have 2 more webinars similar to this coming up, one on January 19th, Tuesday, January 19th at noon, with Dr. Maria Monroe-DeVita, who's going to present on current trends in assertive community treatment research and practice. So please look for announcements about that will be coming out. And on Thursday, February 11th, we will have Dr. Robert Myers presenting on craft and evidence-based treatment for family members of individuals with substance use disorders. So there's a good opportunity to learn about engaging family and significant supports. And then again, January 19th and February 11th. So please be on the lookout for those. We are so excited. Thank you so much, Bob, and all our panelists. And I'm really excited that we got this off without too much of a hitch. And thank you everybody for being here. And please look for those things. And we're really excited to get going with our Center of Excellence.
Well, you did a great job of organizing this. Thank you, and best of luck to all of you at the new center.
Thank you.
Bye-bye.
Bye.